In this video, we're going to be reviewing every nursing student's favorite topic, EKGs. We're going to be going over some of the basic knowledge to understand EKGs. Also, stick around until the end. I'll be including a bonus question to test your knowledge. So let's begin. Hey guys, it's Nurse Aleen from Go Nursing RN. This channel is to provide nursing students with tips and various nursing lectures to help you get through nursing school. If you find this channel helpful, please don't forget to subscribe here below. So let's talk about EKGs. One of the most crucial steps in understanding EKG is to be able to understand the normal cardiac conduction. You also want to be able to describe the components of a typical EKG. So our cardiac conduction system is going to be key to generate and transmit these electrical impulses, which will allow the atria to contract first, then to the ventricles. We all know that we need contraction in order to push that blood out of the aorta into the body to perfuse our organs. So let's review those crucial steps in the heart conduction system. First, we're going to have that SA node, which is also known as the primary pacemaker, or you can think of it as a big boss, which is located at the top of that right atrium. Now, the SA node is going to create an electrical impulses that causes the atria to contract. Then, that signal is going to pass through the second step, which is known as the AV node. The AV node is going to be very important because this is going to be the backup pacemaker of the heart, right? So the AV node is going to pretty much lie very close to the SA node, but it's going to be in the junction of the median wall of that right atrium. So it's going to be in between the area that separates the two ventricles. When the impulses from the SA node end up reaching to the AV node, there will be a quite small of a delay, very short delay. This delay is going to actually allow the atria to contract and empty the blood completely into the ventricles prior to the ventricles contracting. We don't want to lose out on any of the blood. We don't want to cut that atrium short, right? So there is going to be that short delay. The reason for that is also we don't want to have any blood backing up into the atrium. So when we think of the AV node, we also want to think of it as the gatekeeper. The impulses are then going to be sent down to the bundle of His. These bundle of fibers will branch off into two different bundle branches, one that's going to be to the right and one that's going to be to the left. And the impulses are then going to be carried down into the center of the heart, into the left and the right ventricles. Now, almost done, but at the base of the heart, there's going to be bundle branches that divide even further into something called Purkinje fibers. Now, these Purkinje fibers are going to still receive that impulse, and these fibers will then trigger the muscle fibers in the ventricles to contract. Woohoo, we got our contraction, and now they can push blood into the aorta from that left ventricle, and that right ventricle will then send that blood into the lungs via the pulmonary artery. Now, I'm going to give you some study tips of what we just explained. For the SA node, as we stated prior, you want to understand that it's that primary pacemaker, the big boss of that electrical conduction system. It beats at 60 to 100 beats per minute, which is the normal heart rate. So that's usually where we want the heart to actually create the impulse and send that into as an electrical signal into the AV node. For the AV node, it's going to be that backup pacer and can technically take over the SA node if there is any kind of conduction issues. However, it is going to be at a slower rate, which is 40 to 60 beats per minute. Now, if the SA node and the AV node both fail to function and fire, the Purkinje fibers then can take place of them and fire. However, the rate is going to be 30 to 40 beats per minute, which can have serious clinical manifestations because that is a significantly low heart rate. So we do want to keep that in mind. Now let's take a look at the basics of an EKG waveform and what each part means. That's usually the hardest part, and once you get that down, it becomes a lot easier. But before we do that, there is a couple terminologies that I want you to keep in mind as we move forward. Again, you want to really understand the terminology and a little background before we dive into the material. So depolarization. We want to know that depolarization is the moment of muscle contraction. I have a memory trick here, is to think of decompressing or depolarizing. So we're sending out that charge. Repolarization is the moment where the muscle is relaxing. Memory trick for repolarization, especially because we have the RE, think relaxing or refilling with blood. Those are going to be two important terminologies to understand, and now let's go ahead and break down an EKG waveform. When we first look at an EKG, you want to understand what each part is actually doing in regards with the conduction system. So let's break that down first. The P wave is going to represent the depolarization of the atria. Now, quick recap, we know depolarization is going to be contraction. So the atria is going to be contracting during the P wave. The QRS complex, which is also can be called the R interval, indicates depolarization of the ventricles. So contraction of the ventricles. After that, you will have the T wave. The T wave will represent the repolarization, so relaxation of those ventricles. And then you're going to have a U wave. In some instances, it can be present, and if it is, it's the repolarization of the Purkinje fibers. Also, if you do have a U wave, it can be associated with hypokalemia, so we do want to watch out for that. Now, the PR interval, when you're looking at it in the EKG, is going to be the movement of the electrical impulse from the atria to the ventricles. The ST segment represents the early part of that ventricular repolarization. And finally, the QT interval will reflect the time of ventricular activity between depolarization, which is contraction, and repolarization, which is relaxation. So pretty much how long it took to contract the ventricles and how long it took to relax. There is going to be specific measurements of each portion that we just mentioned. These can be calculated by looking at the EKG strip and using the squares that you will see on that specific type of strip to calculate the measurements. Abnormal ranges can lead patients to go into various forms of dysrhythmias. So you do want to know the baseline normal ranges so that way we are able to acknowledge what's abnormal. The PR interval normal range is 0.12 to 0.20 seconds. The QRS normal range is going to be 0.08 to 0.10 seconds. Your QT normal range is 0.36 to 0.44 seconds. So you do need to keep those in mind because we need to know what's normal to know what's abnormal. Now let's start with looking at some basic EKGs. There are going to be 3 different kinds of sinus rhythm. We're going to have normal sinus rhythm, sinus bradycardia, and sinus tachycardia. We first want to think about the 5 steps to interpret these EKGs. What component would make them different? First component we're going to look at is rate. Rate is going to be how fast the heart is beating. So your normal sinus rhythm is going to have a rate of 60 to 100 beats per minute. Sinus bradycardia is going to have a rate that's going to be less than 60 beats per minute, and sinus tachycardia is going to have a rate that's greater than 100 beats per minute. Second is going to be rhythm. Is your rhythm regular? Is the R to R intervals consistent? Are you looking at every QRS and see them marching along the strip? Third is going to be that P wave. Is it upright, smooth, and rounded? And is there a P wave present before every QRS? Fourth is going to be your PR interval. If you remember, we talked about the normal values. Your PR interval should be 0.12 to 0.20. Fifth is that QRS complex, making sure they all look normal and within that 0.8 to 0.10 seconds. So those are the 5 key components when you first initially are looking at an EKG to evaluate them. So now I'm going to provide you an example strip of each one that we just discussed and walk you through the 5 components. So the first one we have on the screen here is going to be normal sinus rhythm. When you're looking at this normal sinus rhythm, we're going to be able to count how many R waves or QRSs you have in this strip to be able to calculate that rate. Now, there are a couple different ways you can calculate rates. One common way is to count the number of R's, which again is also known as that QRS complex. So you have your Q, your R, and your S. That also is called the R interval, in a 6-second strip. Usually all of them are going to be 6 seconds if you're looking at them visually on the screen. And then you'll multiply that number by 10. Another method is using the big box method. And that is done by taking the number of big boxes between 2 R's and dividing that by 300. So this is a 6-second strip. So as you can see, we have 6 R intervals or 6 QRSs. If we times it then by 10, we know that the rate in this 6-second strip is going to be 60. So we know that 60 is going to fall under normal sinus rhythm. Then we can go ahead and look for the rhythm. We see that every QRS is marching with the other one. A trick for that is if you take your fingers and you just put one finger on one QRS and the other one on the second one, and you march them along, your fingers should be marching. That's how you know that your rhythm is going to be stable. Then we're going to look at that PR interval. You can see that the PR interval here is going to be about 0.18 seconds. So if you look along the strip, you don't see that your PR interval is greater than 0.20. So that means it's a normal PR interval. Then we're looking at that QRS interval. The QRS interval stays within that 0.08 to 0.10 seconds, and every QRS looks the same. Nothing looks abnormal. Looking at your P waves, they are all upright, smooth, and rounded, and the P waves also do not look abnormal. That is a quick summary of how to use those 5 components when you're looking at the EKG. Now, the next one that we're going to show you here is going to be sinus bradycardia. Just by looking at this one and comparing it to the sinus rhythm, we see that we only have 4 QRS intervals or R intervals. So we already know that the rate is going to be 40. So we already know that falls under sinus bradycardia. Same thing here, P intervals all look the same, upright and smooth. QRSs look great, they don't look abnormal. They are all marching, so the rhythm is going to be normal. All the differences here is going to be that rate component. That rate is going to be lower, making it bradycardia. Sinus tachycardia. So just by looking at this rhythm and comparing it to the other two, we can see that the difference here is that it's beating faster. We see more QRSs in this strip, so we want to start off by looking at that rate. So if we look at the QRSs, we want to count, right? So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 QRSs. If we times it by 10, because this is a 6-second strip, then we will know that that heart rate is going to be 110. So it's above 100, so we know that we are tachycardic. So we know that we're sinus because the rhythm is still normal. The QRSs are marching all along the strip. That PR interval is normal. Your QRSs all look the same. Your P waves are all round and smooth. And just to keep in mind, sometimes with sinus tachycardia, the heart is beating faster. So you feel like your P wave is going to be eaten up because that QRS is coming really quick. So you do want to keep that in mind when you're looking at it. You might not see the P wave as visual as you saw it or clearly as you saw it with sinus bradycardia and normal sinus rhythm. So just keep that in mind. So this is going to be a great example of the 3 rhythms: sinus rhythm, sinus brady, and sinus tachycardia. Now, let's review the causes and treatment plans of these rhythms. Now, normal sinus rhythm, it's completely normal, right? So no treatment is going to be needed other than continuing to monitor the patient for any changes. Patients in the hospital are going to be on the monitor, especially if they're on a telemetry floor or have a tele order, so we want to keep looking out for any kind of changes. Sinus bradycardia. This is going to be when the heart rate is less than 60 due to the SA node, which is creating an impulse that is going to be at a slower rate than normal. Now, here's a couple causes that can pretty much lead into sinus bradycardia. A lot of trained athletes or during sleep or patients that have hypothyroidism end up having sinus bradycardia. This can also occur due to a response of the parasympathetic nervous system stimulation, like that vagal stimulation. When patients are trying to bear down or trying to move their bowels, they actually can throw themselves into sinus bradycardia. So we do want to be aware of that also in the hospital, especially when we're taking care of our patients. Certain medications such as beta blockers, calcium channel blockers, potassium channel blockers like amiodarone, or even digoxin, also because digoxin is highly to possibly cause toxicity, can lead into sinus bradycardia. So sinus bradycardia can be due to over-medicating the patient or giving them too much of a high dose. So that's something we want to keep in mind. Hypoxia can lead to sinus bradycardia that then can lead into cardiac arrest, myocardial ischemia, sick sinus syndrome, or even severe heart disease. So any patients with low ejection fraction can also lead to sinus brady. If the patient is symptomatic, that is when we are going to actually treat the patient. So these clinical manifestations you want to keep in mind will be pale, cool skin. The patient is going to feel very weak. You're going to take the blood pressure and see that the patient is hypotensive. These patients will also have this angina, which is that chest pain, dizziness, syncope, right? They can even have a full-on syncopal episode. They can also start to get confused and also shortness of breath. Now, if any of these clinical manifestations are occurring and your patient is sinus bradycardia, we need to proceed with treatment. Now, the number one treatment is going to be IV atropine, right? IV atropine is going to be our main treatment for bradycardia. Now, ACLS has mentioned we give 1 milligram every 3 to 5 minutes to a maximum of 3 milligrams. So that's going to be your initial treatment. Get that atropine ready. Now, a lot of patients might not actually fully move into sinus rhythm after atropine, so we want to think about pacing the patient, putting them on a transcutaneous pacemaker for a while until the cardiologist will assess and see what's going to be the next plan. Are they going to put a transvenous pacer, or does the patient actually need a permanent pacemaker in? Also, during this time, you need to start 2 different kind of medications. Dopamine is going to be one of them that can be possible to start to help increase that contractility and increase that heart rate, or also epinephrine. This will be titrated through the patient's response in regards of their heart rate. Sinus tachycardia is when the heart is greater than 100 due to the sinus node creating an impulse that is faster than normal. Now, some causes of going into sinus tachycardia include some kind of blood loss, trauma, also patients possibly that are dehydrated and have a fever, possibly leading into sepsis or hypovolemic shock. Pain is a big one as well, and hyperthyroidism. Patients that also maybe have fluid overload and have heart failure, or anxiety and stress, even a pulmonary embolism, and medications such as epinephrine that would actually cause the patient to go into sinus tachycardia because it's going to stimulate that sympathetic response. Also, patients that possibly are on drugs such as meth or cocaine will also lead their heart to beat a lot faster, leading into that tachycardia. Stimulants that we want to watch out for include nicotine and our favorite, caffeine. So those are going to be some common causes of what can lead into sinus tachycardia. Now, treatment is going to be what is going on with the patient. What's the underlying cause that's leading to this tachycardia? That's going to be what actually guides us into the treatment. Now, for example, if a patient who's experiencing 10 out of 10 excruciating pain, for example, status post a fall in their hip or anything within that kind of scenario, that tachycardia is from the pain. So we know that effective pain management is going to be important in order to treat that tachycardia. In patients who are clinically stable and are having episodes of tachycardia, one of the ways we can treat them is by having them do the vagal maneuver. That's going to be when they actually bear down, and that's known as the vagal maneuver to stimulate the vagal nerve. In addition, we can give them IV meds such as beta blockers. We know couples like metoprolol and labetalol. We can also give them, of course, oxygen, but we want to make sure that we reduce that heart rate because we want to decrease myocardial oxygen consumption and make sure that that heart goes back into sinus rhythm. It is time for the bonus question. Your patient is experiencing fatigue, hypotension, and shortness of breath. You obtain an EKG and discover a rhythm of sinus bradycardia with a rate of 45 beats per minute. What would be an appropriate treatment? Give atropine is correct. With a patient that is actually having clinical manifestations and is in sinus bradycardia, atropine is going to be that first plan of treatment. If you found this video helpful, don't forget to check out some of my other nursing lectures that you'll see up here on your screen. See y'all next time.